Good morning, everybody. Thanks so much for joining us on this Friday morning. We're very excited to have you here and to learn more about the implementation of HPV testing as part of the Ontario Cervical Screening Program. We have a big audience today, so we are hopeful to get through all the information and take as many questions as we can. We will save time at the end of the presentations for questions, just to make sure we can get through all the information. But if you need a little clarification of the information or want to put a question in for the end, please use the Q&A feature at the top of your screen. So without getting too far into our day, I'll do a quick introduction of myself. My name is Sarah Ashton. I'm the regional manager for the Central East Regional Cancer Program, Cancer and Prevention team, as well as the Indigenous Cancer Program. We are thrilled to have Dr. Becky Ray join us today to provide an overview of HPV testing. Dr. Ray is the Regional Primary Care Lead for the Central East Regional Cancer Program. Dr. Ray obtained her master's in sociology at McGill University and her Bachelor of Science at Queen's University in Life Sciences. She completed her Doctor of Medicine at Queen's University and went on to complete her family medicine residency at the University of Toronto Mount Sinai Hospital. Dr. Ray continues her involvement with Queen's University as a community preceptor for medical students and resident physicians. In addition to a busy family practice in Port Perry, Dr. Ray is also a community palliative care physician, attending to patients in their homes, as well as the Oak Ridges Hospice. She also provides primary care to Indigenous patients at the Mississaugas of Scugog Island First Nation Health Center. Dr. Ray sits on numerous boards and committees and is also the primary care co-lead for the Durham, Ontario Health Team. She is passionate about health promotion and works tirelessly to improve the delivery of primary care services in the community. So thank you everyone for joining. I will hand it over to Dr. Ray now. Thanks.
Thank you, Sarah. Welcome, everyone. It's always hard listening to somebody talk about yourself, but I'm excited to be here today. We've got a ton to cover, super exciting changes in the Ontario Cervical Screening Program. So without further ado, we'll get moving because we've got a lot to get through. I want to start with a land acknowledgement. So this morning we're gathered together virtually from areas all across central Ontario, and I'm actually speaking to you from Uxbridge, Ontario. The township of Uxbridge is situated on the traditional territory of the Huron-Wendat, the Haudenosaunee, and the Anishinaabe people, and it's adjacent to the Mississaugas of Scugog Island First Nation and in the territory covered by the Williams Treaty. I have the privilege of providing care for the people of the Mississaugas of Scugog Island First Nation, as you just heard. And as part of my journey in medicine and particularly in reconciliation, I think it's important to acknowledge that the Indigenous people were and continue to be caretakers of this beautiful land. And as part of my journey in reconciliation, I'm working to learn, to always expand my knowledge and learn more. And one of the things that I wanted to share with you today is an opportunity for further training. So our regional cancer program recently won the 2024 Indigenous Health Award at the 17th Annual Cancer Quality Control Council of Ontario Quality and Innovation Awards. That's a big one. But it's for, it's for all the work that our cancer program is doing in educating and really helping to promote safe and culturally appropriate care. And I encourage everybody to consider pursuing some of this education. This educational day that's coming up on March the 21st is offered through our cancer program. It's going to be offered in person at Lakeridge Health. And if you're interested in attending, please send an email to Shannon Burke at her email's on there. So you guys can read that and you'll get the slide deck after. Going through some disclosures. So I do receive a salary from the Central East Regional Cancer Program. I receive for the leadership work that I do. I do also receive a salary from the Durham, Ontario Health Team for the leadership work that I do. And I am the Vice President of the Durham Medical Society, for which I don't receive a salary or stipend. And the financial support for this program is funded by Ontario Health and Cancer Care Ontario. And really, the only potential conflict is that I'm actually paid to be a leader for this program. To mitigate any potential biases, just running through. So the program was designed by Ontario Health and Cancer Care Ontario using evidence-based content, and there is no influence or input from either of my other leadership positions that I have, the Ontario Health Team or the Durham Medical Society. So let's get into the meat of it. So cervical cancer in Ontario, I wanted to just go through some of the background so that it makes sense as we move through into the changes that are coming with HPV screening implementation. So cervical, as everyone knows, cervical cancer is common. And I think the most important thing is that cervical cancer is preventable. When we do cervical cancer screening and we detect cellular changes, and we then send patients to colposcopy and manage those high-grade cellular changes, we actually reverse the journey for that patient and can prevent cancer. And that really is the impetus behind the Ontario Cervical Screening Program. The Ontario Cervical Screening Program, Cancer Screening Program, is a population-based screening program with the goal of reducing the risk for people developing cervical cancer and then eventually dying from cervical cancer. And with screening, there is tons of science that we do prevent cervical cancer. And so really one of our goals in the regional cancer program is to improve screening rates. So currently our screening rate is only 54%. Really overall, and that's not just in our program, that's essentially across Ontario, in that the overall screening rate is really quite low. And there's lots of reasons for that. And implementing HPV screening will hopefully improve screening rates ultimately in the long run and actually further reduce the risk of patients developing cervical cancer. Going to pause there. I'm going to pause at all the blue screens just to make sure that there aren't any burning questions. I don't imagine there's any yet. And Sarah, do you want to just weigh in with a yes or no?
Yep. You're good to go on. Thanks.
Perfect. Thank you. So a little bit about HPV. So HPV infections are incredibly common, as we all know. So the estimate is that about 80% of people in the population who have ever been sexually active will have at least one HPV infection in their lifetime. And there's, as we all know, there's hundreds of different types of HPV, but there are 13 oncogenic types or cancer-causing types. And then there are a few cancer-causing types, 16, 18, and 45, that are of particular concern. Persistent infection with the oncogenic strains of HPV are really the cause of cervical cancer. And so that is the impetus, where the science comes behind the changes to the Ontario Cervical Cancer Screening Program. So natural history of cervical cancer, it takes 15 to 20 years really from HPV infection to evolving to a cervical cancer. In general, we will know patients who have developed this quicker. So there are obviously exceptions to the rule, but in general, it's a longer term process. It's a slowly developing. It develops with low-grade changes, then they progress to high-grade changes, and ultimately progressing to cancer. So that's why there's opportunity for screening to interrupt this process. And so what we want to do is we want to interrupt the process before we get to the high-grade changes and definitely before we get to cancer with treatment. So the natural history, so HPV clearance. So almost all of the time, HPV, we can clear HPV. About 80% of the time, patients will clear an HPV infection within about 2 years. And you can see from this graph that it's really true for almost all of the strains of HPV that we will naturally clear it. So this next graph shows that more than 90% of HPV infections are cleared over time. 5% of infections will become persistent infections, and then 3% of those persistent infections will progress to cervical precancer or cancer. And this is really where we're trying to interrupt the process. There are certain strains of HPV that have more likelihood to progress and they're more difficult to clear. And those strains are identified in the HPV screening that we'll be doing. Pause again.
You're okay to carry on.
So what's the science behind all of this? So effective March the 3rd, the Ontario Cervical Cancer Screening Program will be transitioning from a cytology-based screening program to HPV screening as the primary test with reflex cytology performed on patients who are HPV positive with an oncogenic strain. Okay. There is excellent science to support this. This transition is based on science, and we're going to go through some of the science. So one of the most important things is HPV testing. So testing primarily for HPV is more sensitive than cytology at detecting precancer or cervical cancer in people who have precancer and cervical. So it's a more sensitive test. It's got 96% sensitivity. It's not as specific, but that is why when someone is HPV positive with an oncogenic strain, they have reflex cytology. So that we have a test that now has 96% sensitivity and 96% specificity. Okay, so now we have a test that's not just sensitive, but it's also specific. The other benefit of HPV screening is it's objective and reproducible. So HPV testing it's done by machines rather than cytology, which is done under the microscope, cell cytology by patients. So there are a few additional benefits. And then as you might be thinking, okay, well, what about, what are some other potential benefits of HPV testing? Down the line, you're thinking about self-screening. Can patients do this themselves so that the HPV negatives might never need to progress to cytology? And so screening actually becomes more efficient and more accessible and things like that. So, but the science is that it has much higher sensitivity. And then when you add in the reflex cytology, the specificity is high as well. This slide addresses what I just spoke about. So even though it has the lower specificity, the way that we address that is we add in that reflex cytology for anyone who has HPV positive with an oncogenic strain to bring up the specificity to 96%. When your patient has HPV testing done as part of their cervical cancer screening, all patients who are HPV positive will have partial genotyping done. And this is going to be automatically done by the lab on all samples that test positive for an oncogenic strain of HPV. Okay. And the partial genotyping we'll break out the results into high risk oncogenic strain of HPV and other high risk oncogenic strains of HPV. So the highest risk, 16, 18, 45, and the other HPV positive with an oncogenic strain. And those are actually stratified in an algorithm and how we manage. Okay. And that is important actually when we're looking at the guidelines. So I will bring that up. We will go through it. But essentially, patient comes in, has their speculum exam with their brush collected the same way. We're going to go through that. Results are tested for HPV. HPV negative, one line. HPV positive, they have genotyping done, reflex cytology, and then based on whether they're 16, 18, 45 or another HPV oncogenic strain of HPV is the algorithm that you'll go down. Reflex cytology is also automatically done on all of the lab samples that test positive for oncogenic types of HPV. And the reflex cytology is essentially your PAP test, right? This is looking at the changes that are high grade or low grade. This is the other important part. So the negative predictive values, so the value of HPV, a negative HPV screen is incredible. A negative HPV screen has a high predictive value that in actually extending out to 5 years and 6 years. So of the patient not developing cervical cancer or high-grade changes. So both of these studies shown here. So patient has a negative HPV test 5 years out. The negative predictive value is 99.68%. So 99.68% chance that this patient does not have high-grade changes or cervical cancer. The other study is exactly the same result, essentially 99.7%. So there's what this demonstrates for us is that a negative HPV result has long-term protection against high-grade histology and cervical cancer, extending out at least the 5 years. So in summary, the HPV test will become the primary test for cervical screening and will be used for follow-up testing actually of abnormal results in colposcopy. It will only detect the oncogenic types of HPV. So you get an HPV negative result, it doesn't necessarily mean your patient can't develop genital warts. Okay, so it's only really looking at the oncogenic strains, and then every HPV positive will have reflex cytology and partial genotyping to stratify them into the highest risk cancer-causing strains and the other cancer-causing strains. The benefits of it, it's a better screening test, so it's got better sensitivity, and the specificity is equal because of the reflex cytology, and it's ultimately going to reduce unnecessary colposcopy referrals. It's going to be better for patients, and in the long run, will ultimately, when we are able to roll out self-screening, will hopefully improve screening rates and ultimately reduce the risk of cervical cancer, and it'll improve the quality of screening colposcopy services in Ontario. I'm going to pause briefly. We're going to get into the guidelines, I promise.
There is one question here, just for clarification. Will HPV still be detected if the sample does not pick up on endocervical cells?
Yeah, that is a very good question. Yes, I would say yes, but I will get back to you. We will circle back to Dr. Katasku and answer that question properly for you.
Great, thank you.
Doesn't have to find endocervical cells actually, because the self swabs will be done vaginally. So I know that the answer is yes, but I'll get you the science behind it. Okay. So just very briefly, this is just reviewing what I'd already pointed out. So HPV negative means that there's no oncogenic types of HPV. It doesn't mean that the patient doesn't have any type of HPV. And then HPV positive will be stratified into the very high risk, so 16, 18, 45, or other high risk oncogenic types of HPV. Then the reflex cytology results are it's unchanged. Okay, so this is just a review. So then the reflex cytology, if someone's HPV positive with one of the either the super high risk or the other high risk types of other oncogenic strains, they will have the reflex cytology done. A normal result is a normal result. It's a negative for intraepithelial lesion, the same as we normally get. The low grade types are ascus or LCIL. And then the high grade is everything else. I've circled in red, ascus cannot exclude HCIL and LCIL cannot exclude HCIL because those are actually considered high grade results. And I would say those are the most commonly missed high grade results, right? Because we just look and we see, oh, atypical squamous cells, that's a low grade. But if it's an atypical squamous cell cannot exclude high grade, that's actually considered a high grade result. That needs a referral to colposcopy, and same with LCIL can't exclude HCIL, that needs a referral to colposcopy. So I'm just highlighting it. This isn't actually any change, just an opportunity for quality improvement overall. So the new cervical screening recommendations. So this is the exciting part. This is the meat. So if you've just been working in the background, come on back and listen to us. So eligibility, yes, I've heard some early questions. Are we finally actually going to be the guidelines starting at 25? The answer is yes. So with the move to HPV screening as our primary cervical screening test as part of the program. The age is officially changing to age 25. So have a cervix. Okay, so we're anybody with a cervix. Who's ever been sexually active, and ever been sexually active includes any entry into the vagina. So toys, fingers, body parts is included for ever been sexually active. And then to be part of the Ontario Cervical Cancer Screening Program, OHIP insured, and no symptoms, right? So screening is asymptomatic. We're not screening if somebody comes in with a bleeding with intercourse or dyspareunia. That is not a screening test. That is now a case-based test, okay? So for screening, no symptoms. Age of initiation recommendations. So starting at age 25, I think many of us have actually already been doing this because it's been in the loose guideline already, but this is coming. This is actually an official guideline now. And the start age is the same for people who are immunocompromised. It's the same for people who are vaccinated. The start, and it's anyone who's ever been sexually active starts at 25. And if you've never been sexually active, you don't need to start screening. There's a lot of science supporting the age of initiation at 25. So cervical cancer is incredibly rare under the age of 25, and screening under the age of 25 often really leads to increased testing and unnecessarily follow-up of test and treatment and things like that. So there's really insufficient evidence to benefit screening people before age 25. This is the meat. I'm gonna. This is so we have this. I don't love this view. I actually like the algorithm view, but some people like tables. So we included the table. I included the table so that you could, if you're a table person, you can have a look at this. So this is a results based. So if you're average risk HPV negative, your repeat screen is in 5 years. Okay. If you're immunocompromised, HPV negative, your repeat screen is in 3 years. So the immunocompromised population is screened every 3 years. The average risk population is screened every 5 years. Okay. Those at elevated risk will be referred to colposcopy. So those at the highest risk are referred to colposcopy. And those who are HPV positive with one of those not super high risk oncogenic types with normal or low-grade cytology are a rescreen in 3 years. Believe me, it'll be a bit clearer on the algorithm. So I'm going to just roll through the algorithm. So this is the algorithm. It looks confusing, but once you get your head around it, it's actually pretty straightforward. So patient comes in, you collect their sample, they're HPV negative, they come back in 5 years. They come back in 3 years if they're immunocompromised. HPV positive, they have their reflex cytology and their genotyping. If they're HPV positive with a high risk type, they go straight to colposcopy. It doesn't matter what their cytology shows. Okay, so 16, 18, 45, straight to colposcopy. And then if they're HPV positive with these other high risk types, that's where you're actually stratifying based on their cytology. So if they have high grade cytology, just like now, they go to colposcopy. And if they have normal or low grade cytology, they have the repeat screening in 2 years. So HPV negative, return to average risk screening in 5 years, immunocompromised screening in 3 years, okay? Or if they're at age 70 or their cessation criteria have been met, they stop screening. Why do we screen people every 3 years who are immune compromised? Because immunosuppression might impair their ability to clear their HPV infection. So the 3-year screening interval has been recommended. And the immunocompromised population is well defined in the Ontario Cervical Cancer Screening Program. So it's listed here. You will actually get a package with the list of who qualifies as immunocompromised. And that will, and it don't think it's included on the, might actually be included on the requisition form as well. But you will have this in your package, in your tool package to reference. So you've done your sample. Your patient is HPV positive. They have their reflex cytology and their genotyping, and they're HPV positive for another high-risk type, not the highest risk, but another high-risk type. They have normal or low-grade cytology, so it's either normal or ASCUS or LSIL. The guideline is to repeat their cervical screening test in 2 years. Again, they'll have their reflex cytology, and then and if they're HPV negative, they go back to regular screening. And if they're HPV positive in the 2 years, they go to colposcopy. Okay. The rationale for screening in the 2-year time is that if you screen at 1 year, only 50% will have cleared their infection. If you screen at 2 years, you're getting closer to that. You're approaching that 80% who have. So the 1 year, only 50% have cleared. By 2 years, about 80% have cleared. So you're giving people an opportunity to clear that. Okay. HPV positive, other high risk type, normal or low grade cytology, repeat in 2 years. If they're HPV negative, back to usual screening. If they're HPV positive, refer to colposcopy. Okay. And then again, any of the high grade are going straight to colposcopy. Anyone who's HPV positive with another HPV type is going to colposcopy if they have high grade cytology. Okay. And I think, oh, of course, I'm pausing.
We have a couple of questions. Maybe I'll just ask one or two here, Becky, and then let you carry on. One question is, what do we do for patients already coming in for a repeat PAP? For example, had an ASCUS PAP 1 year ago, and this is their 1 year repeat. Do we start fresh with new HPV algorithm or follow the old one?
Sorry, give me 1 second. I'm just distracted because I'm trying to reload this. So just bear with me and I will come back to that. I apologize, guys.
No problem. There is a question here that I think I'm able to answer, and it was about, will the reports be clear on who needs colposcopy? And the answer is yes. The reports will be clear on what's the next step for your patient.
I don't know why I can't find this slide. Caitlin, do you know what number this slide is, just so I can get back to it? I apologize. My internet, let me just see if I go back into.
Becky, it should be around slide 54 or so.
Okay, perfect. Let me just go back into present mode and see if we. Doesn't want me in present mode. Oh, there we go. Okay, I'll just work my way through. Yep. Okay, I'm good now. So Sarah, if you want to ask that question again.
Sure, no problem. I see it in a couple of places. So it was around, so what do we do for patients who are already coming in for a repeat PAP? So they had an Ask Us PAP last year, and this is their 1 year repeat coming up. Do we start fresh with the new HPV algorithm or follow the old one?
That's a great question. So for patients who are coming in, so we start fresh with the HPV algorithm. So as if they're in colposcopy, if they're in the colposcopy arm, they're going to be taking care of our colposcopists. But if they're with us, if they had an abnormal last year and they're coming back for their repeat, so they had a low grade, right, last year, and they're coming back for their 1 year repeat, we're going to repeat it based on those guidelines. So we're going to repeat that, but they're going to go back, they're going to go into the algorithm, they're going to go into the HPV screen will be their first test run. And if they're HPV negative, there'll be a follow-up for 5 years. If they're HPV positive, then they'll have the genotyping, the reflex cytology, and you'll refer to colposcopy, or if they're any HPV positive, they'll go to colposcopy, and if they're HPV negative, they'll be repeated in 5 years.
Thanks. There's a follow-up question about if cytology will be done automatically or do we need to request differently? And I think that information's coming up shortly.
Yep. So, and cytology will be automatic. So you do your test. So we'll go through how you do your test, but you essentially collect your sample exactly the same way you're doing things now. So ultimately for the patient, there's not going to be a huge change in the actual testing right now. And for providers, there's not a huge change in the actual test right now. What's happening is it's at the lab, right? So it's at the lab where those who are HPV, they'll be tested for HPV first, and then only those who are HPV positive will have the cytology. But the patients won't need to come in for a second test for that. That will actually all happen at the lab level, which is great. Any other questions there, Sarah?
We do have some coming in, and maybe just in line with this one, and then we'll move on and get to these questions at the end. But if someone had a normal PAP this year, when should they be screened again?
If someone had a normal PAP this year, they should be screened again in 3 years. So, because remember, the screening this year wasn't based on their HPV status. So it was based on cytology. So for all of your patients up until March the 3rd, they will be screened based on the guideline. So if they have an ASCUS or a low grade, they need a follow-up in a year. And if they have our normal PAP, they will be screened in 3 years as per our current guideline.
Thanks, Becky. Maybe just carry on and we'll keep track of these questions here for the end.
Perfect. That's great. So what are the changes going to be? So ultimately, for most of us, there won't be huge changes. There'll be changes in the requisition that we use, but really there won't. And then there'll be changes in the frequency that we're seeing patients to do this testing, because all of our HPV negative patients won't be coming back until 5 years. And then the final change will be just learning the algorithm and getting used to it, but it will be clear on the reports that come. So I think the vast majority of us are already using the thin prep. The lab service providers that will be processing the cervical cancer screening program samples are Life Labs and Dynacare in our region. Okay. And if you're not working with either Life Lab or Dynacare currently to process your samples, you will one of Life Lab or Dynacare will be reaching out to you to establish a process for collecting. How will you be collecting? How will they collect? Will they come and pick up your samples or things like that? I think most of us are probably working with Life Labs and Dynacare to process our Ontario Cervical Screening Program samples already. But if you're not, then you will be hearing from the lab service providers in your area to help establish some logistics prior to go live on March the 3rd. Okay, you'll be onboarded. Ordering the tests. So you're going to confirm that your patient's eligible, so that your patient has a cervix, they're age 25, they've ever been sexually active, and they're not finished screening. Okay. If your patient is eligible for screening, they're going to come into your office. You're going to perform a speculum exam the way that we normally do. You're going to collect the sample with the same brush, an endocervical sample with the same brush that we already use because of the reflex cytology that will be performed. And then you're going to complete a new requisition, which will be shared with you prior to go live. There are versions that can be embedded into our EMRs, and the requisition has been updated and has a few more tools that are useful to us as well. And you won't be able to order using the Ministry of Health lab rec, or a hospital rec. Okay, so you have to use the cervical screening program specific requisition, and then you will submit your sample to one of Life Labs or Dynacare for processing. So just a quick review on collecting a sample. So you'll be using your broom-like device or endocervical brush spatula combination, depending on your preference. And there's just a reminder, like the visual. So when you're collecting, to ensure you get an endocervical sample, really ensuring that the brush is entering the cervix, so that we can collect those endocervical cells, like it's shown in the diagram there. In terms of lubricants, so water is using, just lubricating your speculum with water is preferred. That is the most likely way to not get a invalid result. But if lubricant needs to be used, using a small amount of water-based, water-soluble and carbomer-free gel lubricant, okay? And then just putting it on the outside of your speculum, making sure that none of it gets on the inside of the speculum, because that can then get onto the cervix and contaminate the specimen. The brush, so we're doing this already. Again, this hasn't changed, but just a reminder, your brush, so you collect your cells with your 5 turns, then you take your brush and you're smushing it, really distributing it onto the bottom of your tube, of your thin prep, and then the brush does not stay in there, right? So then the brush comes out and goes in the garbage. Do not leave any part of the collection device in the vial itself. Make sure everything is well labeled and that the vial is closed so it's not leaking. None of this is new. So not using the blue, don't use the blue. We can't use the blue. We need to use the thin prep. These are just some tips and tricks to avoid sample rejection. So make sure things are labeled. Make sure you've completed the requisition. Don't leave any part of the collection device in your medium. Check expiry dates and things like that. The new requisition, so don't use the lab rec. You need to use a specific Ontario cervical screening program requisition. And there are some neat requisition changes. So one of the changes is that there is a cheat sheet for us. So eligibility information is at the top of the requisition. One of the other changes is that you do have to indicate where your patient qualifies. So is this average risk screening being performed every 5 years? Is this an immunocompromised patient who needs screening every 3 years? Is this a patient who was HPV positive with another high risk type 2 years ago who had normal cytology or low grade and is having a 2-year follow-up? Or is this somebody else, right? Is there, and those are the last two here. How to complete it. So, I mean, this is pretty basic stuff. So make sure everything is entered. Check only one of the screening test indications. Don't check more than one. And then enter the specimen information here and sign it. The new requisitions will be circulated prior to launch on March the 3rd. And there is a really great source of information, ontariohealth.ca /HPV hub. We'll have all of this information and more. I expect they will actually post their webinars there as well. Jonathan Eisenberg is doing a few provincial webinars similar to this. So I imagine you'll be able to find access to that at that site as well. And then the EMR vendors will be having EMR embedded requisitions as well. This is really no change. So complete the requisition accurately to avoid rejection by the lab, as always. So screening results will be provided to providers. They'll include if the patient is HPV positive, and then if they are HPV positive, what the cytology results and the recommended next steps are. So that question was asked. So the recommended next steps will be included, okay? And if there was an invalid HPV result or unsatisfactory cytology results, those will be included as well.
Oh my gosh, good for you. You've done a lot of reading this morning.
Do you want to just mute? Yeah, perfect. Patients will continue to receive correspondence, so they'll continue to get their notification that their result of the results. They'll continue to get notification that they're due for a repeat, and then physician-linked correspondence. So this is just a plug. So if you haven't signed up for physician-linked correspondence, please go sign up. It's super easy. All it means is that when your patient gets their letter, it says, Dr. Ray thinks cervical cancer screening is important, and Dr. Ray has recommended this for you. And the science tells us that patients are more likely to do something if they believe that their primary care provider feels it's important. And so all you have to do is sign up for it, and it increases your screening rate, and you did nothing. You spent no time, you spent no money, and your patients are better screened. So the information is there to sign up for that. Lots of resources. Again, ontariohealth.ca /HPV hub for all of these resources. And our team, we are here to support you. Please reach out to us. We have a really fabulous team. They are awesome. And we really want to make this, this is exciting. This is very, very exciting for our patients. It's exciting really overall. We're very confident this is going to improve access in the long run and improve screening rates and improve the quality of the program and ultimately reduce cervical cancer. You will receive a post-webinar package that will have your certificate. It'll have information to how to sign up for physician-linked correspondence. It will have a summary. There'll be a link to the webinar, a link to HPV Hub, some Q&A. So if we don't get through all the questions today, we will answer them and circulate them out. And then there'll be a link as well to the upcoming HPV education and competency training. So this is really fabulous, the HPV education and competency training that's offered by Dr. Roth. So nurses can complete this training. If you haven't, it's a nice opportunity. We have in our clinic several nurses who have done their Ontario cervical screening and competency. So they've basically done the PAP competency training, which is evolving to HPV education and competency training. And they're able to offer PAPs to patients as a delegated act. And our nurses are actually super excited to be doing this. It's upskilling. They're being able to do a procedure. It can improve flow in the office as well. So if a patient's late and we're just coming in for their PAP and the nurse has a little bit of time, the nurse can do the PAP. And really overall, it's a great tool to have. So I encourage you to check in with your staff if they're interested in doing this. These are being offered regularly. And you can just use that QR code. We have lots of tools on our website. We have the list of colposcopists in the region. We have a great primary care toolkit. We actually have established an EMR toolbar for managing PAPs that will be evolved to include the changes to the Ontario Cervical Screening Program. And we have webinar recordings. So please use our website. Upcoming provincial webinars similar to today. So the February 4th and February 13th links are at the top. If we have any colposcopists on the line today, there are specific webinars on the 4th and 27th of February for colposcopists. Anyone is welcome to attend, obviously either of the webinars, but the ones that are primary care specific are in the top on the left side there. Be very similar to today, but if you just want to hear it again, or if you know anyone who missed today, please let them know to go to these provincial webinars. And last but not least, our regional cancer program does regular education, and Dr. Kendall is hosting a webinar around abnormal FIT follow-up and surveillance, so part of the colon cancer screening program on Friday, February the 7th from 8 until 9. So I encourage you to join that webinar as well. And we're at the end, so we get to take questions now. A bit of time.
Thanks. So quite a few have been coming in, and as we've mentioned, if we can't get to your question today, we will do a follow-up with all the answers. There's a few themes, so I'll just maybe go through those. One is around patients who are due to come for their PAP between now and March 3rd. Is the recommendation to continue with the PAP in the current program, or wait until after March 3rd and do HPV testing?
Yeah, that's a great question. I mean, there hasn't been an official recommendation. If a patient is in, what we want to do is we want people to be screened, right? And so if you have a patient who's coming in for their exam and they're already booked, or if they're just here and you have an opportunity to screen them, right? Our current screening program is still a very high quality program. So ultimately we want people screened. If patients so I haven't changed any of my upcoming screening. I am screening as per the current guidelines, and effective March the 3rd, I'll be screening as per the new guidelines where patients will be having their HPV testing as their primary screen, because patients just need to be screened, right? And so I think the most important thing is just getting patients screened.
Great, thank you. Another one is for patients who paid for HPV testing in the last 3 years and it was negative, they were told to repeat their PAP in 3 years. Was that the HPV testing the same as that's being introduced? And could providers now tell their patients that they can come back in 5 years? So for those who already had HPV testing.
Yeah, so that's a great question. So as per the new program, patients should still come in when they're due. So patients who are HPV negative, like you're right. I mean, technically the test is the same. If they're HPV negative, they're in a 5-year plan, but the guideline is still to follow, the existing guidelines. So if they're due at the 3-year mark, have them come in, they'll go into the new guideline, the new program. And then if they're HPV negative, it'll be in 5 years.
Thanks. Can you just remind us all, what age do we stop cervical screening?
So we stop cervical screening at age 70, but at age 70, we stop at age 70 if a patient has had three, like currently, right? Three normal exams, three normal pap tests between the age of 60 and 70. And so in the new program, we will stop at age 70 if they've had an HPV. So if they're HPV negative, they'll stop at age 70. If they have had, if that's their they've had normal paps. So right now, if you have a 70-year-old or a 69-year-old coming in and they've had two tests and now they're an HPV negative, they will also stop at age 70. But if you have a patient who comes in at age 69 and they're an HPV positive, they will not stop at age 70. Okay, so they will still need that. They'll have their reflex cytology, and if they're a high grade, they'll go to colposcopy. And if they're a normal or low grade, they still need a repeat exam in 2 years. I'm going to do a second webinar. There was a lot of information to cover today. There are a few more specifics around cessation of testing, and there's also some more specifics around what to do when patients return from colposcopy. And we're going to go through that at a post-go live webinar once we've all had a chance to digest like what we're actually doing and how to manage the original change. Then we'll do some more advanced stuff at a post-go live.
I think we might have time for kind of two more themes that I see coming up. One is around STI testing. Can we still test for STIs using the same brush? And if yes, is there an area on the new requisition to check this off?
No, so your STI testing will be done with your GC chlamydia swab or your red-topped vaginal swab.
Great. And the next, there's quite a few questions here around self-sampling and what's the direction for the province. I know Shannon Burke early in the chat responded to that, but is there anything you'd like to say from a high level what the province is considering?
Yeah, absolutely. So super exciting. We are piloting. So there are 5 to 6 areas in the province who will be piloting self-sampling for this. So this is something that is coming. So stay tuned. It's very exciting. The original group, there's a smaller group that is the first go live pilot, and they're all going live on March the 17th. And then other additional sites will be onboarded over time as well for the self-sampling. And the goal is absolutely that we will be able to offer self-sampling. Self-sampling is a little bit different though. So when a patient self-samples, they're not getting an endocervical sample, right? So self-sampling is actually done with a swab, and the self-sampling has to be reconstituted. So that's the self-sampling that we're doing in Ontario. So the patient still has to do it in the office currently, because it has to be reconstituted in the thin prep vial. So the patient can self-sample in your office as a vaginal swab. It has to be reconstituted by a nurse or physician. And then it goes to the lab for the HPV testing. The HPV negatives are great. They never need a speculum exam, right? Unless they're symptomatic. They don't need a speculum exam. They just come back for another self-sample in 5 years. But the HPV positives then will need to come into your office for a cytology. So that's just because that's how the pilot is working. So stay tuned. If you're in one of the sites who is piloting this, you will know. And if you're not, there will be opportunity in future.
Great, thanks. We're getting through quite a few of these questions. For anyone who's showing signs of cervical cancer, so they're more in the diagnostic phase, what do you recommend are the next steps?
Yep. So if patients are showing signs of cervical cancer, they go to colposcopy, right? If you see a patient with symptoms, we're not screening. So if you see a patient with symptoms, we're looking at their cervix and we're sending them to colposcopy or initiating diagnosis. So then it's not considered a screening test. And also what I should say is unchanged in the new guideline. If you're doing your exam and you see an abnormal cervix, that patient is going to colposcopy. Okay, so you're still going to refer that patient to colposcopy regardless of what their results are if you see abnormalities at the cervix.
Great. I think I see quite a few comments and questions about resources for clinics. So from a regional cancer program, we will certainly take that away and prepare some posters that have been requested and just some information that can be shared broadly. So we will take that away and make that available. So I think, again, multiple questions here we can come back to, but is there any wrap up, Becky, you'd like to provide? And maybe we can let folks have a couple minutes back in their day and we'll take these questions away to answer.
What I wanted to say is, first of all, thank you to everybody for coming and spending an hour of your Friday morning. I hope this has set up your Friday in a great way. I hope this sets up your weekend in a great way. I'm very, very excited about this transition. I think about our patients who, ultimately we will have self-swabbing available and it will change the game, right? So it will improve screening. It will improve access to screening. It will enable screening for patients with history of trauma or patients who, have a lot of anxiety or fear around the speculum exam. Those patients might still, if they're HPV positive, need a speculum exam, but they might not if they're HPV negative. So it's really, really exciting. It's going to improve access and empower patients. And it's better, right? It's better. You saw the science. Using HPV screening is a more sensitive test. So this is good for all of us, and it's really, really exciting. And that's what we're here for. So we're here to support you. Reach out to us, send me an email, give me a phone call. I am happy to answer questions. And if you need a bit more support, that's what our team's for, and that's what I'm here for. So please, please, please reach out.
Wonderful. Thanks so much, Becky, for your time today. Thank you, everyone, for joining us. I've lost my camera ability throughout the presentation, so it's just my voice to say have a great day and thanks for your time today.
Thanks, everyone.
Thanks. Bye-bye.